Okay, good morning, everybody. We're going to go ahead and get started. Thank you for joining me here online. It's Art Holmer from GLMI for GLMI's Expert Webinar Series, Part 1 of 3, Coding in OASIS Review. And this is going to be presented by Laura Page Greifinger from Quality in Real Time. Laura has years of experience in the home care industry, and she's going to be presenting this three-part series discussing first Coding in OASIS Review, then Quality Assurance and Auditing, and then finally Community Health Education. So if you have not received the email, one will be sent out for all those that are actually attending this session with the upcoming dates for those quality assurance webinars. So without further ado, I'm going to go ahead and turn everything over here to Laura. Laura, are you there?
I am, and good morning.
Okay.
Thank you for that nice introduction, Art. Good morning, everybody. As Art said, my name is Laura Page Greifinger. I am the President and CEO of Quality in Real Time. I have been a home care nurse for many, many years, over 40, and about 12 years ago decided to become a consultant. And in my consulting, I noted that a large number of agency issues were caused by quality assurance problems that the agency had and could not deal with. That caused me to develop Quality in Real Time, which started out 6 years ago. It was in response to an observed need for appropriate quality assurance services under one roof. And we did start out as a quality assurance company. We did audits. And we then, as time went on and coding and OASIS review became part of those issues, we expanded our company to include that particular offering to customers. What drives us in Quality in Real Time? Really two things: customer service and exceeding the deliverables of our agreements we have with our customers across the United States. For Quality in Real Time, part of our mission statement, we find that we believe healthcare providers have great value. I also believe agencies should be fairly paid for their services. And over the course of time in doing these reviews, we have found that agencies are leaving a lot of reimbursement monies that are actually due them on the table and actually give the services out but are not adequately reimbursed for them. Patients and payers alike have a right to appropriate quality service for eligible beneficiaries that home care agencies would provide. And honesty and integrity are essential. Now, we have a cadre of credentialed professionals under one roof. As I was a consultant, over the course of time, I met very many people who had excellent credentials and were excellent workers. And I kept in touch with them over the period of time, so that when I started this, I actually had a lot of people who really provided this company with wonderful services. So we find that all of our coders and medical reviewers, who are very difficult to find, as I'm sure a lot of you know, it is very difficult. There are only 3,000 credentialed certified coders in the United States today, and OASIS reviewers are also very difficult to find. So we call ourselves QIRT, Quality in Real Time. We have personnel from 42 different states. We have over 90 auditors who do various things for us across the country. All of the personnel who do coding are HCSD certified coders, and all people who do OASIS review are duly certified as coders and certified OASIS reviewers, either COSD or HCSO certified OASIS reviewers. All of our quality assurance auditors have many years of experience in QA departments doing audits. A couple of them have actually been state surveyors and are very cognizant of auditing charts and so on and so forth. So we have a high-level professional person working for us. All agencies really struggle at times with increased admissions or staffing challenges, and I always think of one agency whose coders, there were 4 in the agency and 3 of them went to lunch and unfortunately were involved in an automobile accident which put all of them in the hospital. All of them are fine, but we assisted that agency in stepping in and doing their coding while their coders got better. So we can step in and we can do it on an ongoing basis. These are the types of things that Quality in Real Time does, and today I'm just going to talk about coding and medical review of the OASIS. Our second part of the series will be on all of the other QA audits that we do, and the third part of the series will be on a new product for us coming out of doing OASIS review, and that is targeted education to the clinicians regarding OASIS. So the review process is broken up because clients want different things. For some clients, we do coding only, and that is done with the assumption that the agency feels that their staff is proficient in OASIS data collection. And for others, we do medical review of the entire OASIS and the 485 that includes coding and includes a review of all of the documents and a correlation between the OASIS and the 485. And some agencies actually have a team for coding and OASIS, and some agencies have a separate team for coding and a separate team for OASIS. So agencies do it differently across the lines, and we do try and collaborate with agencies to see which one works best for them. What I have told some agencies is some agencies don't know if their staff is really proficient in OASIS data collection, and we do have tools that will note corrections that need to be made to the OASIS. And for those agencies, I recommend that they have a 2-month pilot of medical review of the OASIS in 485. Let's look at the outcomes. And for some agencies, their staff is proficient in OASIS data collection, and we moved, moved to coding only with those agencies. Now, why do we do coding and review? Well, coding is done. We want to provide accurate diagnostic data for the state and for the CMS repository. I actually feel that over the course of time, and I ran an agency that was a pilot agency for OASIS in the 90s. I feel that over the course of time, we have probably given a very large amount of flawed data to Medicare and to the repositories that doesn't accurately reflect the work that we do. And I think that this is number one, what this is all about. We have to provide data that shows the services we're providing and why we're providing those services. So a lot of times what we see is a form that says we're going to do something, and then it doesn't match either the services we provide, or there may be some under or overutilization of services that are pretty accurately predicted in the OASIS at the start of care. Coding and OASIS review will address reimbursement for what you do. And it really helps compliance across multiple boundaries. We have seen that by virtue of making sure the data is correctly extrapolated for the OASIS, it ensures compliance with auditing, with surveys, and so on and so forth. ADRs is another one that this helps with. Now, we all know that clinicians struggle with maintaining accuracy from OASIS to OASIS, basically. I've actually done studies on clinicians who do OASIS in the morning versus the same clinician doing the OASIS in the afternoon, and we do find that there are more errors as the day goes on for some clinicians. Interpretations are subjective for clinicians, and there's no real way to really correct this. It is a question that needs an answer, and it's subjective. We, as much as possible, can teach the clinician how to use critical thinking skills to come to the most objective decision as to how to answer the question. The OASIS-C and the 485 must match, and a lot of times we see that this does not happen. And you know, we're looking at this, so when we do our review, we make sure as much as possible that the two document snatch. We do this for collection of appropriate data to the repository that shows the value of home care. People who regulate home care only know what we do, some through anecdotal, but others, most of them know through the data that's given to them. We want to show the value of what we do, and by doing OASIS and 485 review, it assists in showing this picture. The correct picture of the patient and the care that's needed, the correct HERG is billed, and while you have electronic medical records that may validate your OASIS-C, it can't provide the art of the human intervention, the human eye, by a credentialed reviewer. We want to review note trends across, we want to review medications, and we want to review the specific history that impacts the plan of care. The EMR validation validates skip logic, and if you answer a question one way and another question another way, it looks at that particular potential error. But in reality, you really need that human eye on these documents. Now, coding. The process of coding is really, it goes around. Coding's in the middle here. We look at the RN history and physical along with the hospital discharge information. We do look at the medication sheet because a lot of times patients are taking medications that have a diagnosis attached to them, and the diagnosis is not found anyplace in the document. We also work on the official coding guidelines through our credentialed coders. So the process of coding is looking at these three pieces of information and then utilizing the coding guidelines to come to a decision about what the code should be. Now, in coding, the first 6 diagnoses must reflect why the patient is receiving home health services in the beginning. And the first 6 diagnoses directly impact the clinical or the C portion of the HERG. And the sequencing of the 6 diagnoses is very important for reimbursement to the agency because the HERG is determined by, at least the clinical score of the HERG is determined by the coding. Part of that, not all of that. Now, diagnoses drive the HERG score and therefore the CMI for the patient, and that's how the patient gets reimbursed for the episode of care. So the sequencing, as I spoke about in the previous slide, the auditors need to know the primary reason that the patient is receiving home care. And then they will code utilizing coding guidelines, but the primary reason. And Medicare in and of itself, it does expect certain comorbidities to be coded because they impact the plan of care, whether the patient is receiving treatment for these comorbidities or not. And I'll get into that, but vision may be one of these comorbidities that need to be coded for the patient because it does impact how you will deliver your interventions. And Medicare also recognizes that some specific disease processes impact services given to the patient, and they attach more weight on it because you more than likely will need to make additional visits with those particular disease processes. So the pertinent comorbidities that Medicare looks for and assigns more weight to are the following: diabetes, congestive heart failure, peripheral vascular disease, any chronic neurological disease such as ALS or multiple sclerosis, coronary artery disease, emphysema. Now, they recognize COPD, but exacerbation only, not chronic. They do want to know if the person has a history of cancer. Now, I am not sure. They do assign more weight to it, but I also think that the Medicare is trying to get some repository data on cancer statistics in the United States, and it may be part of the reason they look for this. Other chronic conditions which you need documentation to substantiate, or an MD documentation that the patient indeed has this disease process, are Parkinson's, dementia, depression, anemia, GERD, and low vision. So it's very important in this world that you do need documentation to substantiate all of those other chronic conditions. So if the agency is addressing, may not be treating, but is addressing any of their diagnosis, any of those diagnoses in the current episode, and they have, an example is education with a dementia patient and queuing of the dementia patient and documenting it, then these should be placed in the top 6 diagnoses. It does assist the agency in showing the value of home care, in the assessment of the patient and the services that are needed, and it does show why you may need to have more visits with a specific type of patient than another. So with medical review now, the process is a little bit more, don't want to say complicated, but it's a little bit more involved. With medical review, we look at 3 parts of this. We look at the coding, so we look at all things part of that coding, and that is the medication profile, the history and physical, and the RN documentation, the narrative. We also look at the OASIS entirely, and we look at the 485 really in its entirety. Now, there are 2 types of medical review, and basically this has come about because agencies have, on a point of care system, may have data entry a different way. There are some agencies that just have the OASIS M questions filled out on their point of care system. So we do a coding and OASIS review on those systems, which we include diagnosis that impact the plan of care, up to 12 diagnoses because it can, but remember the first 6 are the most important ones. We look at all of the OASIS M items based on clinician documentation and do corrections or recommendations for corrections. We review the 485 to ensure that all locators are filled in on that 485. We, of course, do a medication review to make sure PRN medications have a reason why. And again, PRN visits, they have a reason why. We review the interventions and goals for the services that are going to be given. And we may comment on the need for additional services if the auditor feels that the documentation may show a need for social work services as an example, but that service has not been ordered. We just make a comment on that on a correction tool. There are other agencies that do an integrated medical review with their point of care system, and I know that GLMI, which some of you use, will have this. And so we do whatever it is we do in the coding and OASIS review, plus we look at all the integrated OASIS questions along with the OASIS M questions. We do a complete in-depth review of the 485 to make sure that frequency, duration, services are all listed correctly. We review additional documentation such as TUG or Tinetti scores, the Braden scale, and we do a review of any additional clinician information at that time of review to ensure that it mirrors what the clinician says at the start of care. And this happens when we have 2 disciplines or 3 disciplines perhaps visiting the patient within the first 5 days. Sometimes we see a totally different picture of the patient as documented by the physical therapist and the nurse. There's a great discrepancy. We see a lot of this in the TUG scores. Now, granted, the patient is different at different times, but what we do is that we make comments about it, that the RN clinician noted that the TUG took 30 seconds and the PT noted that the same TUG done a day later took 10 seconds. I'm making up the numbers, but you get the gist of, what I'm saying. We would note that on our comments. So one thing that we do note a lot where agencies really have issues, and that's the safe ability of a patient to do something. So on the guidance for that, we have put this out. Human assistance in the M question refers to a physical assist as well as verbal cues or environmental setup. So that it's not just a person putting their hand on the elbow, but what you need to do to get them to do what you want them to do, to sit up, do you have to change the room to assist them to complete the task. A minimal assist is less than 25%, so that the nurse has to make it, a clinician has to make a decision, how much assistance is needed. And there are two parts to sit in the bed and then bed to chair. And then if any of these items require any kind of assistance to safely complete, whether it's physical or verbal, then the answer to that M question is 1. This is one of the most corrected M questions that we have. This is why we put this down. We do note that clinicians really mark the M question as the person can do the task. However, it's not if they can do it safely. An example would be a patient who ambulates throughout the house with the use of an assistive device, but also holds on to the walls and or the furniture because they are not at all stable. So my feeling is they really not are safe, and therefore the question needs to be answered in a different way. We have OASIS summary reports which are very helpful to our customers. And what this is a compilation of all of the reviews we do in 1 month's time and how many times a specific M question needed to be changed by our auditor. And then at the end of the month, all of the M questions are listed, and then we have made the parameter that a greater than 10% change notes that the agency should follow up with the trends. Actually, our system has now drilled that down that we can pull these reports by clinician as long as that clinician's ID has been put into our portal at the time of review, so that we can see by clinician where they are lacking or are making mistakes that need to be corrected. It has helped in terms of education of clinicians, and with our new education product, this is then targeted to the specific clinicians. It might even be on the same team that you have one clinician who does very well on the functionals and another clinician who really has a lot of corrections in the functional area, more than 10% on each of the M questions in that area. So this is an area that has a lot of corrections, the functional ADLs, and we know that if we raise the functional scores, we do have more reimbursement. It is accurate data, and the services that you put in, because the nurse notes that the patient may not be safe or may need a PT evaluation, then is supported by the correct answer to the question. So it's not the ability of the patient, but the safe ability of the patient to complete the task. Assistance given can be verbal or tactile, and the patient should be assessed on the 50% rule that is observed on the day of the assessment. So more than 50% of the time is what gives you the final answer to the question. And one thing we have found on our education portion is that the clinician should read the M questions responses from the bottom to the top. We have found that clinicians underscore patients when they read them down instead of, reading them from the top down instead of from the bottom up. So that might be a helpful hint. Pain is another area that we find a lot of corrections need to be made on the OASIS. So the clinician needs to assess the frequency of pain that interferes with activities. And an activity could be sleeping. So the clinician has to assess pain through interview with the patient and caregiver. However, the clinician should observe any nonverbal cues. If the patient is limping when they walk, if they're grunting, if they're grimacing, they might not be saying anything because some patients are very stoic. Others don't want you to know that they have pain because they're afraid that you will send them to the doctor or place them in a nursing home. Sometimes it's irrational, but it's a real fear. and then the clinician should use the standardized pain assessments to evaluate. Some trends we've seen, especially with vision, we've seen the OASIS M question marked as a 1. There's no visual diagnosis, and the clinician has to be aware that they have to put the disease process down, glaucoma, macular degeneration, with documentation that the disease process is really in place. One of the most interesting things that I see from clinicians is that they don't read this question. If the question reads, the vision of the patient with corrective lenses, and a lot of clinicians assume that if the patient wore glasses, they had impaired vision, which is not the correct answer to that question. However, patients with vision issues, this does increase the HERG score if it is placed in the top 6, because people who have vision issues take a longer period of time to complete activities of daily living. They have issues with medication administration, perhaps, that people with normal vision don't have. And Medicare does recognize the impact that low vision has on a plan of care and the types of services given to patients. Now, on the discharge OASIS, a lot of agencies do discharge OASIS, and they do them. This is a very important component that is, I think, highly under-recognized by agencies. It is very important to the repository to see the value of home care. And we can only place the value of home care when you look at the 2 points in time, the start of care or restart OASIS and the discharge OASIS. What did home care do in between that gives it value? So the answers to these M questions that are here, which is what we would look for in discharge OASIS, are very important. We want to see, we look at the start of care or the restart OASIS when we do discharge OASIS, and we look at the discharge OASIS to see the difference. We, of course, want to see an increase in abilities, or we want to see that the person who had really severe chronic disease stayed at least stable. So I can't impress on anybody the importance of the review of discharge OASIS. I would also tell you, having done audits over years, that a lot of the adverse event reports consisted of incorrectly filled out discharge OASIS that impacted on the agency afterwards. So when a patient is discharged, there's a look back. We want to make sure the interventions have been addressed in an appropriate manner. Now, CMS compares the OASIS, the start, restart, or rock, with the discharge if there were good outcomes in regards to home care services. And, of course, the potentially avoidable events. This is the cycle that agencies should use in dealing with OASIS review, coding, so on and so forth. And that has to be carried out within a certain period of time. Some agencies are really very good in this process. Others, it takes longer. But it can back up on you very quickly if it is not addressed on a daily basis. So the patient is admitted or recertified, so you have an OASIS. You generate a report to see the new admissions or recertifications. The auditor does the audit and notes there's an issue or clarification is needed. It could be a problem, needs to go back to the clinician or appropriate person within the organization to get the clarification, and then it's, the answer is received, the review can be completed then. So in other words, once this is done and completed, it's really a clean, scrubbed, ready to go 485 OASIS. It has been reviewed, talked about with the clinician approves, and so then the OASIS 485 is locked. The 485 is printed and sent to the doctor, and the wrap is dropped. If there are problems, we have a correction tool, but if there are problems, there must be a process within your agency to get those problems resolved. Sometimes the OASIS comes over with some blanks that need to be filled in. Sometimes the 485 is not correct or not filled in. So before we even would start an audit, we would want that to be completed. Once everything is completed, of course, you contact the clinician based upon the process within your agency. You approve any changes that have been made by whoever makes them. And then, as I said, everything is locked down by the agency, and the bills are dropped, and the 485 is sent to the doctor for signature. It's very important to do this cycle because to get a 485 out the door and back for signature, as you know, many agencies have entire departments devoted to this. It is an issue. I hope that it will not be as much of an issue in years to come with electronic signatures, but right now the process in the agency is usually pretty involved and has a lot of resources devoted to it. So the earlier you can get your 485 out the door for the doctor to sign, it will usually make it back to your office signed within the regulatory time frame. So the value added with coding and OASIS review. Improved agency HERG scores. CMI goes up. Trends are identified and the focus can be placed on education. It is very important to continually educate staff. We have found that some of our customers have devoted a fair amount of time and effort to education, but didn't continue to follow up on it, and those gains were eventually lost over the course of time. So it's an ongoing thing. Education is really a cycle in and of itself. It allows individual focus on problems that may be in one place, not in another, if documentation is kept as to where the changes occur. Now, with this, with the value added of doing coding and OASIS review, we have had some customers who came to us on targeted medical review, or were in the process of having probe audits. We were able to do a review of documentation, including the OASIS and 485, and it assisted agencies in really learning what type of documentation is needed, and then filling in the blanks, so to speak, so that their documentation got better, they weren't denied, and eventually got off of targeted medical review, or never went on, because before the second probe audit came, documentation was reviewed, recommendations were made, and education occurred. We identify needs within the agency, and then we notify the agency of the needs so that the agency knows what they need to act on in a proactive manner. And in reality, one CEO just, I think, said it very well to me. We provide good bookends with our OASIS and 485 reviews so that the agency concentrates on the middle of the story, the documentation that has to occur as the visits occur. And I thought that that was a very good comment. So I open it up for any questions that anybody has. And thank you for the opportunity to present to you.
Okay, so we're going to take a few minutes here and answer a few questions. So on the right-hand side, you see a questions area of your screen, or you can just click the hand button, and you can raise your hand as well. One of the questions that came in earlier is there a way we can print a copy of this PowerPoint out? And the answer is yes. A follow-up email will be sent to everybody who attended, and in there will be a link tying back to the PDF version of this presentation. At the end of this week, we'll do a recap email of the presentations that have gone on this week, and in there will be the posting to the YouTube channel as well. Laura, looks like we have one question here. What is TUG and TNETI?
Timed Get Up and Go. The TNETI, these are validated, actually, fall risk assessment tools that are used. It can be a standardized tool that is used, but it's time, get up and go. A person sits in a chair, is asked to rise, walks 10 feet, turns around, and gets back to the chair. I actually am not sure of the seconds that put the patient at a low, moderate, or high risk, but I believe the longer the seconds, the more at risk they are for falls. It also shows you when the patient turns around, the balance, I think, of the patient as they do a turn.
Okay, any other questions? We'll open up for a few more seconds here. And as always, if you can't think of a question now, but you think of one later, there'll be some information, contact information at the end of this presentation. It says on the GLMI system, only the first 4 of the 5 diagnoses gets transmitted to Medicare for claims processing. Does that affect us? I guess that's one of my questions, isn't it? Or is that your question, Laura?
Nope, wasn't mine. The HERG is really generated on the points that are generated by the answers to the questions. While the first 4 diagnoses may be sent for claims processing, the HERG is processed on the clinical points scored by coding the diagnosis and sequencing them correctly, so that it does go on the first 6. Now, Art, maybe a question that I have for you is this shown in GLMI on that bottom screen there?
Yes, in the GLMI system, you can actually code as many as you want, and only the UBO4, we actually submitted electronically, will only capture the first 4 diagnoses.
Right, but that's for claims processing, and the OASIS data goes into the repository in a whole, as a whole.
All right. Then what I'm going to do now is just kind of remind everybody before everybody signs off. We got 2 more expert webinar series by Laura. One is it's going to be Tuesday, May 15th. That's going to be part 2, quality assurance auditing, and then part 3 is going to be on June 19th, which is also Tuesday, and that's going to be community health education. We're going to, the email that's going to go out will actually have the links to register for those. You can also go to the website and register for those on the calendar. And like I said, the email that's going out will have the link to the PDF, and at the end of this week, we'll have a link to the YouTube channel for this presentation. And here's some helpful information. We'll leave that on the screen. So we'll sign off for the day, and we'll leave this up on the screen in case anybody wants to get a hold of Laura, visit their website. Like I said, if you have any questions that you can't think of now but think of later, feel free to contact us anytime. There's Laura's email address up here. Laura, I want to thank you very much for joining us here. It's very informative information, and I know everybody who tuned in today found it very helpful.
Well, thank you for having me. Thank you for the opportunity to present.